Hi students, good morning. Welcome to chapter 25. This is on male genitourinary system. We're going to list the structures of the male genitalia, name the major structure of the penis, describe the function of the cremaster muscle. We're going to relate the significance of the inguinal canal, and then discuss the importance of teaching testicular self-exam as a health promotion during our assessment. The male genitalia, we know, includes external structures as well as internal. Now, internally, we have the testes within the scrotum, the epididymis, pretty much storage for sperm, and the vas deferens, and that's generally the pathway for sperm. We have glandular structures, additional accessory genital organs. We have the prostate gland, seminal vesicles, and then bulbourethral glands. And most of these are also assisting in fluids that will help the viability of sperm. And the external organs, we have the penis and then the scrotum itself. So what you are looking at right now is just a cross section of a slide between the for the male external genitalia, and then sort of the urinary system as well. We know the urethra is actually part of the urinary system, not only the genital system. And this is the major difference between male and female. For female, the genital system is a little bit different than the urinary system. And so the urethra is much longer in the male, so there is less of a risk for continued urinary infection. There are different types of tissues that make up the penis itself. There are erectile tissues and then spongiosum tissue. The glans penis, if you look at the tip of the penis, is extra or forms a extra skin that actually folds over the top of the penis, and this is called the foreskin or the prepuce. Now, this is sometimes removed surgically by circumcision. Now, all insurances do not cover circumcisions for babies, so new moms will have to double check with it. Although research has said that circumcision does provide the males with less potential for getting cancers from their partners, like HPV cancers, as well as it prevents the partners from getting infections, STI infections, from males. However, you can see cross-section here as well that we have the prostate gland, that the urethra runs directly into the prostate gland, and we'll eventually talk a little bit more about that as well. You see the seminal vesicle, which runs directly in through the urethra, and then the bulbourethral gland as well. You can see evidence of the scrotum as well. The scrotum is pretty much a loose sac that actually houses the testes. And if you look at the skin itself, it has sebaceous glands there, but actually it also has what we call rugae tissue. And depending on the ambient temperature, and this tissue is sort of continuous with the abdominal structure, this tissue actually has a cremaster muscle within it, and whenever the temperature outside the male's body is cool, this cremaster muscle contracts, and then that pulls the testes a little bit closer to the abdominal cavity. And the opposite is true. When the temperature is too warm, it actually lowers it, simply because sperm can only exist at a viable temperature, so it allows that to happen. You can see the internal structure here of the scrotum, which is the testes within it, and above the testes is the epididymis, and the epididymis is pretty much the storage area for sperm. The vas deferens comes off of that, and then sperm would continue down through the spermatic cord, into the urethra, and then of course out the penis itself. Um, and these areas pretty much, if you're looking at the abdominal area, we see that the inguinal canal um, is an area where the spermatic cord actually goes through. Now, these landmarks are important um, just so we can get a sense as to if the patient is going to have some adverse effects, such as maybe a hernia. That would be an area where a hernia would develop simply because it's an open area internally. So again, the testes are hung by spermatic cord, and the testes on the left is actually longer, simply because the spermatic cord is longer. Tunica vaginalis is basically the muscle that actually, or not quite a muscle, but it's an area that actually separates the testes so that they're able to move around the scrotum without actually causing friction. Again, sperm is made in the testes, and then it travels, stored in the epididymis, and then of course travels down the spermatic cord. Sometimes this cord can become twisted, which would cause major pain for the male, whether it's in childhood or in the adolescent years. And that inguinal area of the joint, the groin, again, I say that it's potential area for hernias to occur simply because it's a weak spot in the abdomen. Now, in utero, when before the testes actually descend to where they were, the testes actually started out inside the abdomen. And then as gestation continues, it actually pushes the abdominal wall forward, and then it pulls the spermatic cord with it, and it takes that tract into the inguinal canal area, and then the testes actually goes down into the scrotum sac. There are times where you have an infant that is born and their testes has not yet descended. Once descended, of course, then they consider it descended, although it can sometimes slide back up into that abdominal area. So we have that area of weakness that can occur there as well. And what is a hernia? To define that, well, it's a loop of the bowel can actually protrude through that opening or that weak area. And sometimes this bowel that hangs down can become strangulated, where it can lose blood supply, and then this area of tissue can actually die. And this would be an emergency situation for any patient. If you see in this picture, you can also see where there are lymph nodes that are along those areas. Now, the lymphatic system is still an active system, and so with the lymphatic system, we know that for the penis and the scrotum, the lymphatic system actually drains into the inguinal lymph nodes, and then the lymphatic system for the testes actually drain into the abdominal lymph nodes. And these are lymph nodes, especially the abdominal lymph nodes, where we can actually not palpate them. Now, some developmental competencies generally for older males, unlike females, they do not experience sort of an abrupt change or an end to fertility. Sperm, however, back when they're about age 40 or so, there's a reduction in the amount of sperm that is produced. Now, this continues until the male is about 80 or 90 years old. I'm sure you have heard the stories of like an older gentleman who actually end up fathering a child. And that's simply because there's a lot more sperm available, viable sperm available in their later years. But the drop off really is not dramatic until they get into their 80s and 90s, unlike females who actually have that drop off anywhere between, 40s, thereabouts. So after age 30, testosterone declines as well. And there are some changes that you'd see just like females, so you'll see changes because of the estrogen reduction in the body. You'll see this in male in looking at their muscle tone. Look at a younger male in their like mid early to mid 20s, look at their muscle mass, how they're, sort of buffed and have a lot of muscle tone. As they get a little bit older, actually testosterone helps with that muscle tone. But with a reduction in testosterone, then you're not going to have the muscle tone being supported. So you're going to have sort of weakened muscle tone or sort of flabby muscles. So the scrotum itself will actually hang a little bit lower because it's more loose, more relaxed. These muscles tend to be more relaxed. And so we'll see scrotum that are more pendulous. Also, there is less sperm production that occurs, and the size of the testes is smaller. And then with erection, it's actually less firm as well. Males can also have a slower response and a less intense reaction during sexual intercourse as well. So in adolescent, then we know puberty actually starts a little bit earlier in African American, and with this society and or overweight society, we're seeing the development and with the induction, I guess, of hormones and lots of foods, etc. We're seeing the beginning of adolescence a little bit earlier. So about 9 in African Americans and then 10 or so in Caucasian or Hispanics. Generally, with adolescence, one of the first things that you see in males is enlargement of the testes, and then the pubic hair actually begins, and then we'll see a change in the size of the penis. It becomes larger. When we are teaching males about changes in their body, we look at Tanner's sexual maturity rating chart. This is what we use to teach males about changes in themselves. Now, as we get a little bit older, we have some changes that also occur in male. Now, not because a male has like a reduced, say, orgasm or reduced firmness in the penis as for sexual action. It doesn't necessarily mean that there is sort of sexual failure that occurs. All that male needs is basically a willing partner. Although there are some other things that actually causes some, changes to their sexual expression in life. Their libido may have been reduced, or maybe they don't have any privacy. They may have moved back in with their children, or maybe they've moved to a nursing home. And sometimes, nursing homes don't necessarily put husband and wife together. There are some that actually do a good job in doing that. But still, you have staff going in and out all the time, so there's a lack of privacy there. Older patients take medication, and so you may have medications that cause side effects that actually affects a person's libido. They may have lost their spouse, so there's no one available for that male to, have a sexual release. And then maybe it's just the disease process itself. Sometimes older patients have cardiac issues and they get very fatigued. And so engaging in these sexual activity would actually over fatigue the person and would not, they wouldn't be able to function appropriately. Nutrition can also be a problem as well. And then we have older patients who actually use alcohol, and that can be a detriment to their sexual health as well. Although the commercials may not say so, but in reality, alcohol use is not cohesive with sexual activities. Now, remember I spoke about the foreskin and that circumcision can occur. It gets approved for some insurances, and then other insurances it does not. Now, this is again a removal of the foreskin itself. Normally, with removal of the foreskin, again, it can prevent males from having cancer, decrease their risk for urinary tract infections, etc. And then STIs, development of STIs, and then passing on STIs as well. And also, the foreskin is removed, males would be at risk, they would lower their risk for phimosis. Okay? Phimosis, sometimes males get circumcised simply because the foreskin prevents the area from being retracted, the penis from foreskin retracting over the penis. It's too small of an opening, and so sometimes they have to get circumcision in order for that retraction to occur. Now, speaking of that, I know some of you work in healthcare, and so if you have an uncircumcised male and you've pulled the foreskin back to clean, please be sure that you're actually replacing it, because it can actually cause an emergency if the foreskin is stuck in place in the back. It can actually strangulate the penis, and we don't want a male to actually have a penectomy done, removal of the penis, because of something that we have done. So let's talk a little bit about chronic diseases like kidney disease, simply because the urethra is a part of the GU system as well. So when we have decreased kidney function, if it's say damage to the working portion of the kidneys, these are the nephrons. If it's less than 3 months, then we call it an acute kidney infection. If it's greater than 3 months, about 6 months or so, then it ends up being a chronic problem. So normally if the chronic kidney disease occurs, we'll find some changes, and we can see this in the lab values. Normally, creatinine would be a lab value that would be elevated. The patient's BUN would be elevated as well. And we see their glomerular filtration rate actually dropping off. Normally, it's 125 milliliters per minute. And that's pretty much the amount of blood flow that the glomerulus sees going across, or the kidney sees going across the glomerulus. We need that blood flow in order for the kidneys to work. Two of the main causes for kidney failure would be hypertension and diabetes. And think back to how many patients you may have cared for, or how many patients have diabetes and hypertension in our society. A large amount. So many of our patients are at risk for kidney disease. Now, African Americans are far greater. They're more at risk, 4 times more at risk than other groups for having kidney problems. One, because maybe they have more hypertension and diabetes. Low socioeconomic status, insurance is a problem, so lack of insurance. And then, of course, when these problems are identified, they're sometimes also identified in the later stages. And so this could happen as well. And, sort of mistrust of the medical profession as well has caused males not, African American males not to necessarily go to seek care. And so when these problems, they find these problems, it's usually in their later stages. So these things end up leading to end-stage renal disease. And when you get end-stage kidney disease, what we're talking about then for management is either transplant, so kidney transplant, or dialysis. Some of the subjective complaints that you may hear would be a patient having problems with urination. So they feel like they really need to urinate, so the urge is there. Frequency can also be there as well, because they have to go all the time simply because they didn't empty their bladder the last time they went. So that frequency is there. And then on occasion, sometimes male get up at night to urinate. Sometimes patients with heart failure have what we call nocturia, which is frequent urination at night. And this is simply because during the daytime, where the body is commanding this metabolic action to occur, it's sort of shunting, blood supply from the kidneys. And so the kidneys are not functioning as well. But when a patient is laying down more supine in a recumbent position, then the blood supply gets redistributed over the body. And so now the kidneys are seeing that it actually, that blood that was in, or fluid that was in the extravascular spaces, now can actually go back, get reabsorbed into the intravascular spaces. And so there's more blood supply in circulation. And so the kidneys would then see a lot more blood supply going across the glomerulus and then begin to actually function. And so with reabsorption, then the person needs to get up and urinate. And so more frequent urination at night. Also, males may be taking medications such as diuretics that would cause urination as well. Now, a term that you may also hear as well is oliguria, and this is a reduction in the amount of urine. We have generally less than 400 mLs in 24 hours. Dysuria is when the person has pain with or burning with urination, such as when they would get the urinary tract infection. Now, this kind of pain could either be from where the urinary tract infection is. It could be in the bladder, which would be cystitis. It could be in the prostate gland, prostatitis, or it could be in the urethra called urethritis. So straining could occur as well. Now, I called your attention to the prostate gland that's actually surround the urethra, one of those first slides. Sometimes that grows a little bit. It gets larger, and so when it does that, it actually causes the urethra to be squeezed in between it. And so men will have difficulty urinating, and so they're always straining to urinate or feeling that they have to go, but they're pushing in order for the urine to come out. So that could cause a problem with straining or hesitancy. Um, and we call what they generally have is BPH, benign prostatic hypertrophy. Now, sometimes it turns into cancer, but not necessarily all the time. Sometimes there's maybe a urinary stone that could be a problem as well. We look at urine color, and it gives us a sense as to what's going on GU-wise, excuse me, with the male. If there's an infection, sometimes the urine can be foul smelling. It can be a little bit cloudy. Excuse me. And we think maybe a urinary tract infection could be ensuing. If it's a little bit bloody sometimes, could be because maybe they've had surgery, and with surgery such as if they had a prostate gland removed or transurethral resection of the prostate gland or TURP, there could be some bleeding afterwards, which is quite normal. Inflammation of the nephrons could actually cause some bleeding. Now, the urine color could also appear as blue, and that could definitely be because of food or dyes that they actually use. So blue would be maybe asparagus can cause it to be blue. We also use dyes that can actually change the color of the urine as well. And there's some medication that can actually change the color. Ladies, you may be familiar with azo or pyridium, which is given for as a urinary pain medication, and it generally yellows the urine. So there are certain things that actually causes the urine color to be a little bit different. So other questions that we generally ask is if men have problems controlling their urine, such as when they laugh or talk or, bear down, like they're coughing, if they lose urine. And we call this incontinence. There are two different types of incontinence. It's either stress incontinence, which is related to like a weak pelvic floor. This is where there's stress on the abdominal cavity, the abdominal area. So like sneezing or coughing or laughing would put pressure on it. And then there is urge incontinence, and that's generally due to like an overactive detrusor muscle that's causing it. And you're never sure when this is going to happen, but all of a sudden the person becomes incontinent. They lose urine. And we sometimes think about this in like if they're having a urinary infection. So when the bladder becomes a little bit irritated, then it actually sort of the urgency is there. You cannot really hold on to the urine in the bladder. Anyone that has a UTI is aware of this. You have the urgency. As soon as you feel the need to go because of the irritation in the bladder, you really need to go. Sometimes it causes pain in the flank area. And so one of the tests that we do would be a CVA tenderness with your health assessment. Remember CVA tenderness where your hand is flat on the person and you do with the base part of your thumb, you hit your other hand on the person in order to see if they have any discomfort in the CVA area. That's one test that we could actually do as well. And then we ask about other infections that the male may have. So we look at potential problems with the penis, such as maybe any kind of lesions, or maybe there's discharge coming from the penis that we potentially would associate with an infection or like an STI or urinary tract infection. Problems with the scrotum would be any kind of lumps that are felt or pain that's felt within the area. Sometimes the scrotum can be swollen as well. A person can develop a hernia in the scrotum. I don't know if you've ever seen this. But sometimes maybe even a loop of bowel can actually descend all the way down, follow the inguinal canal, and drop all the way down into the scrotum. Now you have scrotal hernia. Um, and then spermatocele or hydrocele, these are issues that can actually occur as well. And in your book, in the back of your book, in these chapters, you have some great pictures and description of those things that can occur. So other questions that we ask generally, because this is a sexual organ as well, is maybe involvement in sexual intercourse. Are they involved? And also who the partner is. Now, again, with puberty, we have changes in the male. We spoke about that already. But sometimes it's not necessarily a heterosexual relationship that occurs. A homosexual relationship can occur where males have sex with males. And that could cause some emotional upheaval as well. So sometimes there is a lack of acceptance within the medical community or others, family members as well. So there's sometimes a lack of social support that actually occurs. From a healthcare perspective, of course, we have to treat everyone the same, doesn't matter what the person's sexual orientation is. We have to love the person and accept the person for who they are. You may not, agree with the behavior, but for that individual person need to feel sort of acceptance and feel that they are loved and cared for in order to relate. Because sometimes these individuals will not state what is going on with them, and then because that person will not be accepting. So then maybe an issue would end up going on to become cancerous because they were afraid of mentioning this to the healthcare provider. So we ask about sexual preference. And then when we are asking these questions, of course, it needs to be matter of fact. We need to be professional about it as well. We do know that men having sex with men can increase the risk of STIs, and then, psychological trauma and distress as well can actually even lead to suicide. For children, we would ask the provider about children that are maybe, sort of holding their private areas, their penis, and maybe crying um, or having problems urinating. Then we would make sure that we are assessing for urinary tract infection. As well as for sexual abuse, we're assessing for that as well, because it can occur, babies all the way up to the older person. So we screen for sexual abuse as well. And we ask the younger children, has anyone touched you between your legs and you didn't want them to? And remind the children really that they have not done anything to cause this. They're not the bad ones. And ask if they have like three big people person outside of their home that they can actually share some information with. Because we know that most molestation actually occurs by the parent. The parent who's supposed to be supportive and protective are actually the ones that are either involved in or they are aware of what is going on. Our society has now become so evil, and our children are at risk. So for the adolescents, some of the questions that you may want to ask, and it's important how these questions are phrased. If you're going to ask the boy, do you usually have discharge from your penis? The answer is going to be no. So how we ask it is important. You may want to say, often boys your age experience. Okay. This means that, they're not the only one, and so they don't feel left like they're out there on a limb by themselves, and you're more likely to get a better response. Or maybe you may ask, when did you begin to, instead of saying, do you have, right? More than likely, you're not going to get a good response there. And then we, of course, encourage testicular self-exam with males, in their teenage years. They can actually begin that. Although testicular cancer is rare, but it can sometimes happen to young men. Again, and of course, not every time that there is a tumor felt or lump felt means that it is cancerous. So the cure for testicular cancer is almost 100%, which is great. So with testicular self-exam, what we normally do is We teach in a mnemonic, TSE, the T is for timing, which is done once a month, just like breast self-exam for the ladies. The S is for shower. When they're in the shower, the hands are soapy. This will be the best time where the testes are more relaxed and they can easily feel for a lump in this area. And then E is examine. So you want to check to make sure that everything still feels the same. They're not necessarily checking for cancer, they're checking to become aware and familiar with what their body feels like so that when there is something different, they can actually pick it up and report it immediately. And generally what that necessarily feels like would be maybe something hard, sort of a little bit more painless, and then doesn't really move a lot. So we pay attention to those just like we would with breast cancer. Now, when we are doing the assessment, of course, our first thing would be inspection. So we're going to look and inspect the penis and the scrotum. Generally, we're looking for any kind of infestation that may occur, any kind of discharge that may occur. Sometimes there's a hydrocele that occurs in children and they complain of pain. Sometimes torsion of the spermatic cord can occur as well. And we're also looking for any kind of hernias within the area, any kind of bulging in the area as well. So we are going to report anything that is reported subjectively by the patient when we are documenting the frequency of urination, what the color of the urine is. You know, do they have to get up at night? Are they having any pain or discomfort when they urinate? Any kind of discharge? And then report any other thing as well, any kind of STDs, if they've had surgery, all that is reported. And of course, then our objective data, what we see, what we assess, and then we continue to move from there. So some of the changes in the prostate gland, again, we would do a PSA test, which is a prostate-specific antigen test for diagnostic purposes. And generally, they're looking for an elevated number. They don't want to really see it elevated. So like maybe 4 or less would be awesome. But as males get a little bit older, again, the prostate gland undergoes some changes or hyperplasia that occurs. Doesn't necessarily mean it's cancerous. And then they also do a digital rectal exam at the same time. And that's simply because of the location of the prostate gland. Where they can go into the rectum and feel, because when the prostate gland enlarges, it actually encroaches on the rectal area. So here's a question for you. The nurse is reviewing the importance of testicular self-exam with a 17-year-old male. Which statement by the patient confirms the patient's understanding of TSE? I will check my testicles for lumps in the shower. I will bear down and check my groin area while seated. I will check my testicles while laying on my right side, or I will have my testicles examined by my healthcare provider every year. The answer is 1. So we'll examine the testicles for lumps in the shower. That's the proper technique. The nurse is obtaining a sexual history from an adolescent male. Which of the following will be the best way to begin the sexual history interview? Often, young man your age. I worry that you might. Do you? You don't. Do you? And the answer again is 1. So often young man your age. You want to be sure you're not putting them out there on a limb by themselves. And then just some hissy hints. Signs and symptoms of enlarged prostate gland. So probably hesitancy with urine, straining to urinate. Testicular sense of self exam, TSE. And then some age-related differences between the adolescent, older male, some changes, hormone level, etc. And sometimes male take erectile dysfunction medication. It will have sometimes side effects, like the little blue pill that you are aware of, right? It can have side effects that could be a potential problem as well. So some abnormal findings, these are also in the back of your book, so you can continue to look through these. You'll see genital warts that you can actually see on the genital areas, sometimes syphilis that has the canker that you can see, and maybe some drainage or discharge, swollen lymph nodes could occur. And then you may have kidney stones that can actually develop. Inflammation of the urethra can actually develop, so urinary tract infection there. Phimosis, paraphimosis could occur, priapism could occur, and you guys need to actually look in your book for these are some common things. So you may want to pay attention to some of those areas. And then some abnormalities in the scrotum itself, where you have epididymitis, varicocele, maybe a spermatocele that occur, a tumor, scrotal edema. So these are things that you can see related to the scrotum. And then the inguinal area as well, you have inguinal hernia that could occur.